my name's Anthony Glover. I'm an endocrine surgeon from Sydney. And so for this talk, we're going to explore how to recognize and manage unusual parathyroid conditions. I have no financial conflict of interest to declare. And I'm pleased to say 95% of the time with us as experienced and trained endocrine surgeons, we can get that winning feeling when we do a parathyroidectomy. But no matter how good or how experienced or how many tricks we know, unfortunately, sometimes when we treat parathyroid disease, we're going to feel this feeling. So how do we recognize and look for unusual parathyroid conditions? And how can we avoid them and hopefully stay safe on the playing field and try and achieve the best results that we can for our patients? So in this talk, I want to focus on some unusual causes of hyperparathyroidism and hypercalcemia that we may see as surgeons, and hopefully allow us to recognize them so we can avoid surgery in some cases and maybe adapt our surgical approach in others. I'm going to focus mainly on FFH that affects the kidneys, and then touch on lithium-induced hyperparathyroidism, parathyroid malignancy, and parathyroid crisis. And central to this story is the calcium sensing receptor, which is a widely expressed G protein coupled receptor that mediates numerous functions. And while we think of this receptor being present just on the parathyroids, it's actually present on nearly all tissues in the body. And the calcium sensing receptor has multiple binding sites for calcium and phosphate, and both ions are essential for the functional integrity of the receptor. When the calcium ions are present, they stabilize the active state of the receptor and allow it to signal to mediate its intracellular functions. Whereas phosphate ions act to inhibit the receptor and reinforce the inactive conformation of the receptor. The receptor can also be activated by magnesium and different amino acids. So while we usually think of calcium and phosphate as being essential for this receptor's function, it is not always that straightforward. So one disorder that is related to dysfunction of the calcium sensing receptor is FHH. And it's one condition as surgeons we have to recognize and get out of the way of, as our patients will not benefit from surgery if they have this condition. So in FHH, we have an inactivating mutation of the calcium sensing receptor gene, which results in altered calcium sensing and therefore an inappropriate parathyroid hormone release with respect to the serum calcium concentration. This inactivating mutation affects all cells that express the calcium sensing receptor, and is the same mechanism for some rarer neonatal forms of severe hyperparathyroidism. This is in contrast with what we well know, primary hyperparathyroidism, which we all know and love, which has this parathyroid tissue specific decrease in extracellular calcium sensing by the receptor. So in FHH, or familial hypocalciuric hypercalcemia, there is a loss of function of the receptor. So this leads to a decrease in sensitivity to calcium, which shifts the calcium PTH curve to the right and leads to hypercalcemia, since higher concentrations of serum calcium are required to suppress and activate the receptor and suppress PTH release. So this resets the serum calcium concentration to a higher than normal level. The degree of hypercalcemia seen in FHH can be quite variable, and it depends on the particular gene mutation. There's well over 100 different inactivating gene mutations described, and also whether the patients are homozygous or heterozygous for this gene mutation. FHH is generally an autosomal dominant condition and has quite a high penetrance, so it quite often will be seen in families, but it can also happen sporadically. No matter what the cause of the mutation, they lead to fewer than normally functioning receptors on the parathyroid or the kidney. So how do we recognize FHH? So the key is it's usually nearly always asymptomatic. So the patients don't have any signs of calcium end-stage disease. Although there are some rare cases in the literature where patients have had pancreatitis or chondrocalcinosis. The hypercalcemia is usually mild, and the serum PTH is usually normal or inappropriately normal or high in about 20% of patients. When thinking about FHH, you have to be careful of having a combined vitamin D deficiency, which will make the PTH higher. And the absence of a high serum PTH concentration is thought to be why these patients usually have a benign clinical course, as compared to primary hyperparathyroidism, where you'll see a much higher PTH. It's always important to remember, though, that a hypercalcemia with a normal serum PTH can occur in about 10% of patients with primary hyperparathyroidism, which is a much more common cause of hypercalcemia than FHH. So for patients that have symptomatic disease, it's highly unlikely that they'll have FHH. So how do we distinguish it from primary hyperparathyroidism? And the easiest way we can do this in the clinic is by looking at the urinary calcium excretion. For patients with FHH, the urinary calcium excretion is usually low. And while you can test this on a 24-hour urinary calcium, a more accurate way is to use the urine calcium to creatinine ratio. So in my clinic, I use the Hammersmith urinary calcium creatinine calculator. This is available from Google. If you put in that title, you can actually download this Excel spreadsheet. And with this spreadsheet, it can be used either with a 24-hour urinary result or a spot urinary result. And for patients with primary hyperparathyroidism, the calcium creatinine ratio is usually higher than 0.02, while for patients with FHH, the ratio is usually less than 0.01. For patients who fit in the middle range, like in the example of this patient here, it's always important to think about other factors that could cause hypocalciuria with hypercalcemia, such as vitamin D deficiency, if the patient has a very low calcium intake, mild renal impairment, or if they are on drugs such as thiazide or lithium. So most studies using these ratios have used 24-hour urinary results, but it is thought that spot testing probably provides a similar accuracy as this as a spot test. So if you think your patient may have FHH because they have asymptomatic mild hypercalcemia and they have a urinary calcium creatinine ratio which is suspicious or less than 0.01, you need to sit it out. There's no role for surgery, and you will not do your patients any good by exploring their neck. What you do need to do is involve your friendly endocrinologist or genetic counseling service, but it's important to remember that genetic testing for mutations of the calcium sensing receptor is no means infallible. depending on the study, up to a third of patients will not have a detectable mutation. For these patients with their ongoing care, it's important to consider genetic testing for their families and avoid parathyroid surgery. In very selected cases, there have been case reports of hypercalcemia improving in FHH with surgery in the very rare cases of hypercalcemia-induced pancreatitis. We always must be aware as well that these patients can develop an adenoma and benefit from removal of that. So moving on back to the parathyroid, the next unusual condition that I'm going to discuss is lithium-induced hyperparathyroidism. So lithium increases both the serum total and ionized calcium and the PTH levels. And this usually occurs within weeks of starting lithium treatment. However, only about 10 to 20% of patients will develop clinical hypercalcemia, and around 2 to 3% of patients on lithium will develop hyperparathyroidism. Using lithium also increases the serum magnesium and decreases the urinary calcium concentrations. Lithium acts to do this by decreasing the parathyroid gland sensitivity to calcium and shifts the set point of the calcium PTH curve to the right in a way similar in FHH. While we generally regard that lithium induces this altered calcium sensing across all parathyroid glands and would lead to hyperplasia, it is dependent on the duration of the lithium therapy. And for patients that have been treated with lithium for less than 2 years, it is quite common to find adenomas, often with double adenomas, whereas for patients treated with more longer-term lithium therapy, it's much more likely that they will have a clinical four-gland hyperplasia. The reasons for this is not clear, but it's thought that possible that lithium unmasks adenomas in patients with pre-existing parathyroid disease within a few years, whereas for patients with hyperplasia, this change is slowly induced with chronic use. For patients that have lithium-induced hyperparathyroidism, if the lithium can be stopped without exacerbating the psychiatric condition, the hypercalcemia may resolve, and normalization of serum calcium is most likely in patients who have been treated with lithium for less than 1 year. So when we treat these patients, it's probably worthwhile for us to think that they have four-gland hyperplasia. However, if they've had a short treatment of less than 2 years and they have a localizing study, it could be considered that they could have a more focused approach. But in general, it's worthwhile considering that these patients have hyperplasia and need a four-gland exploration. Moving on to parathyroid cancer, it's exceedingly rare with an incidence of less than 1 per 2 million, so even rarer than adrenal cancer, and definitely probably almost as rare as the Wallabies winning the Bledisloe Cup. How do we recognize a patient with a parathyroid malignancy? Generally, the patients will always have symptoms. They have large tumors, most of them being over 2 grams. About a third of patients will have a lymph node metastasis, and about a third will have distant metastasis to the bones or the liver. With their symptoms, it's highly likely they'll have kidney stone disease. With the hypercalcemia, it's usually marked, and nearly all patients will have high serum PTH, more than 4 to 5 times the upper limit of normal. For some patients, it can be hard intraoperatively to distinguish between a parathyroid cancer and an atypical adenoma. And in these cases, the parathyroid should just be resected. And if there is no other obvious metastatic disease, it does not need to be further treated. For patients where there is obvious lymph node disease, then a lymph node dissection should be undertaken. For patients with metastatic disease, there are unfortunately a few systemic options, and most of the treatment revolves around controlling hypercalcemia. Although there is some interest in sequencing these patients and seeing if they have any targetable mutations, unfortunately, as they are so rare, it is difficult to develop experience with them. So finally, we'll move on to parathyroid crisis, which affects about 1% to 2% of patients who have been untreated for primary hyperparathyroidism. And it presents with serum calcium concentration of above 3.8 millimoles per litre and symptoms including central nervous system dysfunction, nausea or vomiting. For these patients, it's essential that initial management involves endocrinology with aggressive rehydration and bisphosphonates. For some patients, they will not respond to this and they can benefit from surgery. For other patients who initially respond, they should have surgery to avoid any further parathyroid crisis. If parathyroid crisis is untreated, it can lead to death. So I hope this has been a nice walkthrough to recognize some and manage some unusual parathyroid conditions. I think the one that we may see most commonly is FHH and lithium-induced hyperparathyroidism. I think we always need to carefully consider the clinical features to recognize them. And for lithium-induced hyperparathyroidism, always think hyperplasia for patients that have had a longer-term treatment, which many of these patients have. And for parathyroid cancer, think for patients with symptomatic disease with big glands, high calcium and a high PTH. So thanks for listening, and I look forward to any questions.